Do a mic check. Sorry about last week. I had actually hit the mute button on the Yeti here, and the first few seconds of my first question were muted. But I'm gonna upload that video onto YouTube, and I'll edit out the part that was not audible. So for those that are logging on, thank you. Just give me a quick thumbs up or okay that you can actually hear me okay, and then we'll get started answering the questions. So. All right. All right. So the first question up tonight is a 45-year-old person with a clearly 20 millimeters of plaque volume. Their ApoB is 90. They're on a low saturated fat diet. They're hyperabsorber. Should they still try for an ApoB of 70? I can't give individual medical advice, but and pretty much anybody who has any demonstrable plaque, an ApoB of 70 would be a good goal because that would put you less than the 20th percentile. But if you have other risk factors, then potentially ApoB of 55 or less. If you're hyperabsorbing, potentially ezetimibe might work well in addition to whatever else you're trying to do to lower the ApoB. All right, thank you everybody. Give me the mic check that it's working better tonight. Last week was my fault. I just didn't hit the unmute button on the Yeti mic here. So, all right, what are my thoughts on the multifunction cardiogram? I've done the device twice at the A4M conference in Las Vegas. Interesting device. They're choosing AI to look at the the electrical fields coming off the heart. So it's basically a fancier form of an EKG. Interesting. But it's one of the things where it's probably just cost prohibitive for most practices to obtain it. The device is somewhere in the neighborhood of $25,000 for the device, and there's a fee for each time that you run the device. So I think it's an interesting device, but I think the price point for it is not ready for prime time yet. I think tests that look at the endothelioglycocalyx would be a more interesting test ultimately. But there are many tests that can look at the nitrox availability, which we've obviously talked about in this forum before, with the pulse wave velocity testing, the endoPET scans, the salivary nitric oxide strips. I would look at those first. The MCGs would be add-on after that, in my mind. Next question up tonight. This is a very broad question, but is there an effective way to lower ApoB? The answer is, of course, yes. It's just, what are you willing to do for it? There are different lifestyle interventions for some people that will work. If you're insulin resistant, work on your skeletal muscle health, and potentially your insulin resistance gets better. You'll improve your ApoB. If you're eating a high saturated fat diet and you're somebody who has a response to saturated fat raising their cholesterol and lowering the other receptors, then switching out the saturated fat for more monounsaturated fat or polyunsaturated fats like fish may help lower ApoB. That being said, if you're already doing all the lifestyle interventions, sometimes supplements such as bergamot, berberine may have an effect. But if you're not getting to your target goals, and usually the goals are based off how much plaque you have in your arteries, then medications like the statins, bempedoic acid, if you're a hyperproducer sterols, that's what that will work. If you're a hyperabsorber sterols, then ezetimibe works. And then in between those two stages would be the PCSK9 inhibitors. Right now they're all injectables. That's Repatha, Praluent, and there's also a infusion of ilisagolirine that you can get every 6 months. They are working on some oral forms of PCSK9 inhibitors that should be out in the next year or two. So yes, many effective ways to lower ApoB. And somebody's asking, is low-dose testosterone replacement therapy okay after having a heart attack? The person's 39 years old with a testosterone level of 147. So the more concerning thing is, why did somebody under the age of 40 have a heart attack? Elevated lipoprotein A would be high on the list. So you'd have to know what the root cause of the heart attack was before saying that it potentially is okay for be on testosterone. Again, I cannot give medical advice in this situation. So you have to work with the doctors who prescribe the testosterone initially and work whoever your cardiologist is to see if they're comfortable having resume it. That being said, if they found the root cause for your heart attack and have effectively treated it, then it's potentially safe to go back on testosterone replacement therapy and maintain levels that are generally between 500 and 1,000 on the total testosterone. Question about lab values. So somebody says that they have high LDL particles and LDL particle size. I think it's the small LDLs are also high with low HDL particle. How do they fix it naturally? This goes along with the previous question. If you're insulin resistant, work on skeletal muscle health. If you're eating a high saturated fat diet, then maybe change up the types of fats that you're eating. And then really look at, are you truly doing enough exercise? If you're lifting weights 3 times a week and you're doing some type of cardio 30 minutes most days of the week, then probably lifestyle alone isn't going to get you there naturally. And so then maybe reconsider things such as bergamot or berberine. Question about statin use. So which statin has the least side effects if somebody has to be on one? Typically, it's going to be either pravastatin or Livalo, which is pitavastatin. The reason I probably would hesitate a little bit on the Livalo or pitavastatin is that it's still the only brand name statin, and so there's no generic available for it, and it's often very pricey if insurance doesn't cover for it. But that one tends to have the least side effects. Other times you may be able to get away with using low-dose rosuvastatin and just intermittently pulse dose it twice a week. That being said, you also want to make sure that you have optimal vitamin D levels above 50. You don't have low CoQ10. Ideally, your level's over 3. You don't have hypothyroidism. You're not an ApoE4 carrier. And if you've done more advanced genetic testing, like looking at SLCO1B1, you would know if statins are going to be more likely to cause you symptoms or not. All right. Lots of good questions tonight, guys. Keep them coming. Question about Lp(a). So what do you recommend for management of elevated Lp(a) levels? So there are not great effective treatments that significantly lower Lp(a) at this time. The best are probably the PCSK9 inhibitors if you have access to them. But that being said, you generally want to look at some labs to see is Lp(a) more likely or not damaging the arteries. So if you have high levels of Lp(a)2, which is also known as the plaque test, PLAC, that means that there's vascular inflammation and Lp(a) is more metabolically active. If you have high oxidized phospholipid ApoB, that's cargo that the Lp(a) is carrying. And if you have high interleukin 6, then the liver is cranking out more apolipoprotein E proteins and sticking them on the LDL particles, and then your Lp(a) levels go up. So you want to see if those labs are elevated. And then mostly it's about managing the ApoB particles that are on the LDLs, because still 90% of your ApoB targets or totals are going to be LDL particles. So you can use the cholesterol balance test on the Boston Heart Lab panel to determine, is it more likely that you're a hyperproducer of sterols or hyperabsorber of sterols, and that might guide your treatment options a little bit. But there are some very novel agents coming to the market, the antisense oligonucleotides. There's also, I believe it's called the single interfering RNA medication that will lower Lp(a) by greater than 90%, but they're still working on the phase 3 trials to look at does it actually lower cardiovascular events. So it's great that it lowers the labs, but do the patients have less heart attacks, strokes, die less frequently? That's what we're still waiting to find. But the other option, and I've never honestly sent patients to it, is apheresis. More popular in Europe, but apheresis, when they take your blood out, put it through a machine, pull out the lipoprotein A, and then give you your blood back. But it's not a permanent fix, and you have to have a center near you that you can go back and do it. Switching gears to an exercise question. So which zone 2 training method is better? A run walk outside with heart rate in zone 2, or inside on a trainer at steady heart rate, zone 2? So the default answer is if you can get exercise outside, that is always the preferred way. You don't want to be working out in a blue lit gym if at all possible, and if you do, we would ideally keep your eyes protected with glasses like this and your skin covered, because you do have melanopsin receptors in your skin. But the trick with working outside is that it has to be probably a level surface, so maybe a track, because if you have a lot of inclines, you're going to have a lot more increases in your heart rate during that period. But if you have a nice flat piece of ground, outside would be the preferred method. Question about triglycerides. Can you lower them with a fasted morning cardio for a biased lower positive result? Possibly, but I mean, it's one of the things where it's like, your triglycerides are going to change throughout the day based off of what you're eating, and so if you're just trying to game the system to have a low triglyceride, yes, you of course could do that, but what are you eating the rest of the time? So that'd be my more concern if you're trying to kind of win the game of having a super low triglyceride. But it's mostly about having very healthy skeletal muscles. So really, you want to make sure that you've been doing enough resistance training, that you have enough muscle mass, so that when you do the fasted cardio, that any glycogens can be used up, and that any carbohydrates that you've ingested from the evening before get burned up quickly. Is using whey protein to meet protein goals while trying to lower LDL, ApoB, and particle number a bad idea? No, not necessarily, and it's something I recommend to many patients. Some patients have intolerance to the dairy component to whey, but if they don't have a intolerance, they know it's a good source of protein, because 90 grams of protein a day is the minimum that you're really trying to shoot for to maintain your muscle mass. So no concerns with your lipoproteins and whey protein. Question about sodium tonight. Do you need to restrict sodium to prevent cardiovascular disease, or only if you have hypertension? Well, sodium, if it's at a high enough concentration, will be damaging to the endothelial glycocalyx, the lining of your arteries. The glycocalyx buffers the sodium. So if you have high blood pressure, often you have issues with your glycocalyx and you have low nitric oxide, so that's one reason to be more sodium restricted in those individuals. If you do a test from Vibrant America, it will actually kind of show you if you're more likely to be salt sensitive or not. So not everybody has to be tightly restricted. There's a ballpark answer, but like generally 4 to 6 grams for the average person. But if you have high blood pressure, heart failure, or definitely if you have kidney disease or liver disease, you're definitely have to salt restrict to what your doctor wants you to. Somebody's asking about nitric oxide boosting supplements. Is it safe to use them multiple times throughout the day? Like anything, it is a drug, essentially in your body, and none would be fatal, and too much can be a problem. So there is always a sweet spot for almost everything. And so you'd really need to know more context of why somebody would want to take it, quote, multiple times per day. Most of the nitric oxide promoting supplements, are dosed either once a day or twice a day. There are some nitric oxide powders that can be added to water to be drank before exercise, but you probably would only do one of those a day. But you could use test strips, and if you're getting bright pink levels, there's no reason to keep utilizing more and more nitric oxide throughout the day if your levels are already high enough. How would you treat a young child with FH without statins? So this is outside my area of expertise. I'm an adult cardiologist, board certified. I had an interest in congenital heart disease when I was in my fellowship, but decided I want to take care of adults because it was a little bit too sad for me to see some of the sick kids not make it. But FH, is a problem in 1 to 200 to 1 to 300 people. So, statins have been utilized in these cases in young individuals. But if the person is not tolerant to statins, or if the question is like prefer not to, then I don't know all the literature as well on this, but potentially consider PCSK9 inhibitors if it is an option for the pediatrician who's treating the patient. Question about reversing atherosclerosis. Yes, it is possible. The first goal is to find out that you have atherosclerosis, so using some type of imaging to look at the plaque in your carotid arteries or coronary arteries to stage it, then doing blood work and a good history to figure out why you have the plaque, and then it's really about 3 buckets for the most part. support nitric oxide pathways if they're deficient, lower oxidative stress and inflammation if they're elevated, and third, lower ApoB to target goals, generally less than 70. And then the blood work, if you have high uric acid or high homocysteine or you're insulin resistant, fix those things. So stop doing damage, and the body has a better shot at starting to regress the atherosclerosis. There are some supplements. Kylo Gauge garlic is one of them. Arterial Protect have been shown to help stabilize plaques as well, and there's a few others, but it's based off of your biomarkers and kind of having a good history. But that's what we do all day at Apollo Cardiology, try to stabilize plaque and get it to reverse. All right, so I'll answer the question, but definitely not an expert on this. Somebody's saying, what is my suspicion as to why people have different heartbeat abnormalities with COVID? It's likely because the spike proteins damage the glycocalyx of the microvessels, and the heart tissues themselves may be impacted, and that's what's causing some of these atrial fibrillation, premature ventricular contractions, postural orthotic tachycardia syndromes. So that is probably the reason, is it's damaging the microcirculation or the cardiac tissue directly. All right, what are my questions on remnant cholesterol? So, the remnant particles, those are, VLDLs, ILDLs, and chylomicrons, which, you're not usually going to be able to measure. Generally think of them as, markers of how insulin resistant you are. You can monitor them on Cleveland Heart Lab panels and Boston Heart Lab panels, but it's really about the ApoB particles first. Yes, the ApoBs will contain the remnants, so do what you need to do to get ApoB to your goals, and if you're insulin resistant, fix that. Question, if it clearly showed 0 plaque, are there other tests to confirm no issue with any arterial issues or endothelial dysfunction? So Clearly is a AI software company that utilizes state-of-the-art software to analyze CT coronary angiogram images. It will quantify the degree of plaque in the arterial wall. Plaque is kind of like an iceberg. It grows in the wall of the artery before it obstructs the flow in the lumen where the blood flows. I've honestly never seen a man over the age of 40 have a clearly that's completely normal. They always had at least some degree of soft plaque. I've seen a couple of women with scores that have been 0. But if you truly have a clearly with a score of 0 total plaque volume, that's outstanding. Then you need to look at the other 60,000 miles of blood vessels, because just because you don't have plaque in your coronaries doesn't mean you don't have plaque in your carotid arteries or your brain arteries or your aorta or your iliac arteries. So in my practice, we do carotid intimal medial thickness scans on every patient. We do AAA ultrasounds, which can quantify if you have an aneurysm. We do ankle brachial indexes, which look at blood pressure in your arms and legs, which will give you an idea if you have significant plaque in your iliac arteries or the arteries going down to your legs. And then the endothelial function, that's mostly the endopat scan that really quantifies how much nitric oxide your arteries can release when there's a vascular stressor. All right, what's my favorite brand for red light therapy or photobiomodulation? I have many. If you go to my website, redlightdoc.com, there's a few links to the companies that I've utilized. I either personally have the devices or I've spoken to the engineers / owners of the companies, and I believe that their products are well designed and have the proper specs, because that is the challenge sometimes with the red light companies, is that quality does matter. If you get a device that's underpowered or has the wrong radiance or the wrong wavelengths, you may not get the benefit, and then you don't believe red light therapy could work. It's basically like trying to use a flashlight to cook a turkey. It's just not going to ever work. So listing them, EMR Tech, that's what I have in my office. Solbesa makes some nice portable ones. Gimba Red makes some excellent ones as well. Those are probably the top 3 companies that I generally recommend. Are there any concerns with the inactive ingredients, injectables like Repatha? Not in my experience. I've not seen many patients at all have to stop Repatha other than it just didn't work well enough for them. injection site irritation is the main side effect most people would experience. But I've not seen any issues with the inactive ingredients. This is a question that I don't necessarily know the answer to fully because it would depend on what is causing it, but when a stone forms in the gallbladder, is it the same material as plaque and calcification? I mean, there's likely a lot of cholesterol in the gallstone, but is it the same as plaque? I mean, there's other things in the plaques like monocytes, they become macrophages, they're smooth muscle cells, so it's not going to be the same thing exactly. Question up, can taking calcium for bone health cause atherosclerosis? Not directly, but if you don't have optimal levels of vitamin K2 and vitamin D, then taking excessive oral calcium can cause kidney stones and potentially can worsen vascular calcification if the arteries are already inflamed and there's lipoproteins getting retained in the artery and kicking off that inflammatory cascade. So you definitely do want to talk to your doctors about the dose of calcium, and if you're on oral calcium, make sure your optimal vitamin D levels and that you're on vitamin K2. All right. All right, there was a question about if somebody has a gallbladder removed, where does the extra cholesterol plaque settle inside the gallbladder? It doesn't that mean that you're going to have cholesterol plaques just because you don't have gallbladder, but it does mean that it's harder a little bit to digest certain fats because you don't have a repository to store bile. But the bile ultimately gets dumped into the gut, and that's how it's eliminated. All right. Well, those were some great questions tonight. I got a few more minutes. I'll answer a few of the comment ones. And I did put a poll up. It looks like the winner so far is people want me to kind of show them some of the ways to test your arteries at home. I'll show you kind of a teaser of some of the things that I'm currently testing out, and then I'll set up a time to do a kind of more formal IG Live where I go through them. Thoughts on ApoA being more important than ApoB? No, it's not. ApoB is more because it's more about preventing the damage than having ApoA try to go in there and clean up the damage. So the ApoA protein's on the outside of your HDL particles. The challenge is that it's a variable number of ApoAs on the outside of each HDL particle. It's not a one-for-one like it is with LDL particles or LPLAs. So ApoA, I will check it on occasion in people, but mostly just follow HDL particle numbers. Should one do a genetic test to determine the root cause of heart disease? Often the answer is yes. I pretty much always start with LPLA, ApoE as in echo, 9p21, which is the heart attack gene, and then KIF6. Those are the top 4 that I check. And then depending on if the person has significant elevated blood pressure or elevated lipids, there are other companies where you can do more SNPs to look at what's the root cause. All right, somebody's giving me some gratitude for answering their questions, and they're hoping to fly out to see us in a few months. That'd be awesome. We're always welcoming patients at Apollo Cardiology. We have many patients from out of town. I've had a couple patients from Canada, and I think Bahamas is the other kind of far location. So if you're interested potentially in working with us at Apollo Cardiology to have us get to the root cause of your cardiovascular concerns, you can just go to my website. It's drtwyman.com. And we have an application there, and then Cassidy on my team will set up a call with you. And there's a question about what is CoQ10. Somebody took like a 200 milligram dose, and they felt that their heart was beating strong, so they stopped it. So I can't explain why you would have those symptoms. Often CoQ10 is utilized in patients with palpitations, but that being said, if you had side effects, you had side effects. But your body's making CoQ10. It's used inside the mitochondria to shuttle electrons. And in a cardiovascular world, statins and beta blockers, those are the two biggest agents that will deplete your CoQ10 stores. So often patients with heart rhythm issues, high blood pressure, congestive heart failure, or on long-term statin use will be on CoQ10 because some thought is that if your levels are lower, that may be one of the reasons why people have muscle symptoms taking statins. What are the options to fix a left bundle branch block? I don't know too many of them, honestly. A left bundle branch block is often a marker of ischemia. So if you have severe atherosclerosis, then treating that. If you have a cardiomyopathy where the heart has already been weakened, then potentially the conduction system has been damaged. So trying to find the root cause of what caused the bundle branch block would be key first. Somebody's asking about why are PVCs painful? They're not always painful, and it's more that it's just that it's a more forceful beat where people feel that sensation. So when the periventricular contraction happens, the sinus node is paused for a second, and so the left ventricle has more time to fill with blood, so the next beat is going to have a more forceful beat. Somebody's asking if I'm a fan of methylene blue. For myself, yes. For everybody, not necessarily. You have to do some particular testing to know if you're a good candidate for it. And there are still some concerns that getting proper dosing without causing side effects. There was a very good podcast recently with Dr. Nathan Bryan and Dr. Scott Scher on Scott's podcast, where the question was asked, does methylene blue impede nitric oxide? And you have to go into that podcast to get the detailed answers, but it is possible at certain doses of methylene blue. And so since, I'm often talking about vascular health, you have to be very careful at anything that can lower nitric oxide availability. And so somebody's asking about pleurisy. Why does the chest hurt when taking a deep breath? Would need a lot more history before knowing for sure, but, if you've had a recent viral infection, possible. If you have pericarditis, possible. Pulmonary embolism, possible. Pneumothorax, possible. So you would have to have a good physical exam and history to know for sure. And somebody's asking, what is a cause of muscle cramping in the feet? Could it be low CoQ10? Possible, but low magnesium, potentially low B12 might be a contributor to that as well. So, all right. Well, I did kind of a speed round with you guys tonight and got through them all in half an hour or less, kind of like dominoes. So hope you guys are having a great week. Next week, I'll be back Monday, 6 p.m. Central Time. And, looking at the poll, it looks like it's going to be the, home testing. So, I'm, going to go over the nitric oxide test strips. I'll go over, the watch that I've been using lately that looks at blood pressure non-invasively. It also will look at glucose levels, not so accurately, but the blood pressure is pretty decent. And then there's various devices that look at pulse wave velocity. They clip to your finger, and they're looking at how elastic the arteries are. It will also give you arterial ages. So these are some of the kind of like home devices that you can potentially acquire to kind of test and see, are things going in the right direction? Most of the time they do correlate pretty decently with the devices I have in the office, such as the Max Pulse and the EndoPAP. Not perfect, but they at least kind of give you an idea if things are headed in the right direction. So, I'll put together a little video for you guys to do that. I don't have a date yet in mind, but it'll probably be in the next 1 to 2 weeks. And if you miss it on Instagram, these videos are always recorded, and I'll put them up on my YouTube channel, which is just youtube.com/Dr Twyman. So hope you guys have a great rest of the night, and we'll see you next time.